Hello, everyone. My name is Sylvia Hujek,
And I'm Sarah Wack.
and we are the summer education interns with the Jacobs Institute. We are so excited to welcome you to the Jacobs Institute Heart, Health, and Wellness webinar. We are so thankful that you have joined us this evening.
The Jacobs Institute is a medical innovation center located on the Buffalo Niagara Medical Campus and sponsors collaboration between clinicians, researchers, engineers, and entrepreneurs to develop medical devices to improve the treatment of vascular diseases. During tonight's webinar, our guest speakers Lisa Neff and Dr. George Matthews will discuss cardiovascular diseases, treatment, and how to be our healthiest selves. Additionally, our other education intern, Sylvia, will lead us in a mini stretch break. Lisa Neff is the Senior Community Impact Director with the American Heart Association, and Dr. George Matthews is a cardiologist and the Chief of Service at Kaleida Health's Department of Internal Medicine. Questions and comments are encouraged. Please type any questions you may have in the chat box on Zoom during the webinar. Questions will be answered during the Q&A section scheduled in today's program, which will be located at the end of today's program. Please keep all questions and comments appropriate and respectful, as this webinar will be recorded and posted to the JI's YouTube page. Without further ado, I would like to present the JI's Heart, Health, and Wellness webinar.
I think that's my cue. Hi, everybody. Good evening. My name is Lisa Neff. I am the Senior Community Impact Director with the American Heart Association. I'm really excited to be here tonight, and thank you to the Jacobs Institute for having us as the Heart Association. Obviously, this is a topic that is very much a point of passion for us. And I'm actually celebrating my 8th year with the American Heart Association as of July 14th. So it's been a wonderful journey with the American Heart Association, and I look forward to sharing some of that with you tonight. Really high level, what I'm going to do is go through a little bit of who we are, what we do, and the work that we are rooted in. And I'm going to touch a little bit on some of the Buffalo Niagara area statistics as well, just really high level. But I hope what you get out of this tonight is just a good framework of some of the work that we do as an organization, how it impacts us locally here in the Western New York region. And please feel free to ask questions. I'm going to try to do a couple interactive things. We'll see how that goes tonight. But first and foremost, who we are. The American Heart Association is a relentless force for a world of longer, healthier lives. That is our mission. It is who we are as an organization. We do this work through collaborating with numerous organizations such as the Jacobs Institute, and we are powered by millions of volunteers who allow us to fund innovative research, advocate for the public's health, and share life-saving resources. Again, I'm going to talk about lots of things that we do today, but just like a few things to keep top of mind that I always find most fascinating, and I sometimes didn't even realize the scope of work that we do as an organization until many years in really learning about the American Heart Association. We're the nation's leader in CPR education and training. We do consumer education and help people really understand what it means to make healthy lifestyle choices. We provide science-based treatment guidelines for healthcare professionals so that they can give the best quality of care to their patients. We educate lawmakers, policymakers, and do public advocacy to change and protect and improve the health of our communities. We also work with so many people from workplaces, schools, community-based organizations to make a culture of health for all people. And it's also worth noting we are the largest private not-for-profit funding source for cardiovascular and cerebrovascular disease research next to the federal government, funding more than $4.6 billion in research, really thanks to our donors and supporters. And over the course of the Heart Association's journey, we've actually funded 13 Nobel Prize winners. And the research advances that we've done as an organization collaboratively have been just amazing to see over the years. So the work that we do really is centered around some core priority areas. And you'll see on this image right now that equity is truly at the center of everything we do. And I'll talk a little bit more about that later as well. But I think it's really nice sometimes to see this image to just understand that even though we've narrowed our focus a little bit more, we did it really intentionally, actually right when COVID was hitting. We were in the process of coming out with new health impact areas, and COVID kind of encouraged us to really focus our efforts and make sure that we were being the most impactful organization possible. And this is how we do that work. And where we do that work is really interesting. So you'll see on the map here, the different colors actually represent the 5 different regions of the organization. And our headquarters is down here in our national centers in Dallas, Texas. We're actually celebrating our 100-year anniversary very soon, this next year actually. And then you can see the little star there. That's where our local work happens. So we are a single nonprofit organization, which is a little bit different from some other large nonprofits that people may be used to. Everything is centered at our Dallas-based office, but then all of our work really happens in our local communities like the Buffalo Niagara Regional Office. And even though we're the American Heart Association, we are also making a global impact. Cardiovascular disease is still the #1 killer globally, and stroke is the #2 global killer. So a lot of work still needs to be done. I'm not going to spend much time on this slide, but it is really fascinating to just see how much work is done on the global sphere as well as our local. And over the course of our work, again, really driving for change. It's amazing to see that we have actually reduced cardiovascular disease deaths, reduced stroke deaths. Just in the time that I've been in the American Heart Association, when I started, stroke was the #4 cause of death within the United States, and it's since dropped down to the #5 cause of death in the United States. So it's really interesting to see those changes. Now, I'm going to talk a little bit more about this. You'll see we are kind of starting to backslide on some areas. So what are the needs in our community? Real fast facts for you here. Heart disease globally, but also in the United States, is the #1 cause of death. In fact, 1 out of every 3 deaths in our country today is caused by heart disease or stroke. For the folks that are in the room today, you should have the ability to interact, maybe, hopefully. How many of you have a family member or friend or yourself have been impacted by heart disease or stroke? I don't know if you have reactions, but feel free to also put it into the chat box if you have been personally impacted, because this is something that most likely in a room of people, there's not one individual who has not been impacted by heart disease in some way. And then also quickly about stroke, as I said before, it's since dropped down to the #5 cause of death in the United States, but it's actually still our leading cause of disability. So even though we are surviving strokes, the quality of life afterward may not be what we want people to have, because it's not just about living your life, it's about living your best life. And so we want people to be strong and healthy when they're coming out of a disease impacting them. 2 types of stroke really quickly for people. There's either an ischemic stroke or a hemorrhagic stroke. Ischemic stroke is the one that is a blockage. Sometimes we kind of think of it like a heart attack happening in the brain. The hemorrhagic stroke is a bleeding stroke. And very quickly for everybody in the call today, you can actually help save a life by spotting a stroke fast. Just remember that acronym, SPOT a Stroke FAST. It stands for face drooping, arm weakness, speech difficulty, time to call 911. It's all about acting fast. Now, I mentioned before that we've made some significant improvements to heart disease and stroke statistics over the years. But COVID has really impacted the number of deaths across the country. New data from CDC did show that the life expectancy for people in the United States did fall by 1.5 years as an impact of COVID-19. And the sharp decline was mostly a result of the COVID-19 pandemic, which ranked in 2020 as the #3 killer of Americans. But heart disease still remains our single greatest health threat and our #1 killer. But we do have to be cognizant of the impact of COVID-19 and the impacts that it has had in our community and the long-term We call it the domino effect. We saw a lot of people during peak COVID times not seeking out care, afraid to call 911 when health emergencies were happening for fear of going to hospitals and health centers. I think we've all seen and experienced the ripple effects of the economy and the economic stress that put on so many families in our community, people struggling to get access to healthy foods, supplies, and their prescriptions. And unfortunately, we have seen down the line higher rates of high blood pressure, cholesterol, diabetes on that more preventative care side with people who were not going for their ongoing clinical care and maintenance. So quick look closer at Western New York. I wanted to kind of pull some of this to give you a rough idea. So in our general area, it's about a little over 30% of adults with high blood pressure. Now, what you see on the screen right here are county level numbers. Chautauqua County actually ranks the highest, which sometimes people are a little bit shocked about that within our Western New York community. Sometimes rural communities actually end up with some not so great numbers because of other challenges that they may have for access and other things. But really important to note when you start looking at a city level data. So county level, we were at roughly 30%, but then when you drill into specific zip code areas, you can see here some of the rates over 50% for high blood pressure. Which leads me to our impact goal. Ooh, my screen would go, there we go. Our impact goal at the Heart Association is that every person deserves the opportunity for a full and healthy life. We are truly trying to be champions for health equity. And what I mean when I say that, equality is one thing, but equity is another. We want to get the right resources to the right people at the right time and make those interventions meaningful to them. The same thing is not going to work for every single person, and we have to really start addressing health like that. And when you think about health, we call it the social determinants of health sometimes. They can affect up to 80 to 90% of a person's risk factors. So that's everything from clinical care, how you are treated when you go to the clinic, what that clinic does and follows guidelines, health behaviors, what you eat, what you drink, what you do, that all matters. Where you live, unfortunately, zip codes can have a huge impact of your health outcomes based on where you live. And then there's social and economic factors like your income, your support system, your social network, things like that. When we talk about health disparities, we have to draw attention to the fact that this work is urgent, and that is why we are here right now. This slide is actually showing the death rates over the past 10 years. It's a little bit dated and it doesn't take into account the COVID pandemic numbers, but Black people are 32% more likely to die from heart disease than white people. And even though death rates among Native Americans and Alaska Natives are dropping, they're not dropping at the same rate they are for white people. So we have to look at what we're doing. And then when you look at the age-adjusted total stroke mortality rates, even worse, unfortunately, Black people are 45% more likely to die from stroke than white people. For Latinos, Native Americans, and Alaska Natives, that the decline in death rates is not keeping pace with the decline for white people. So again, there are health disparities that exist. And when you look just within the Buffalo Niagara region, what you're seeing here is a 2-mile stretch between these 2 points here. Again, this data is a little bit dated and does not take into account the COVID-19 pandemic, but it's really interesting to see just a 2-mile stretch from Gates Circle to City Honors Public School. The life expectancy can vary by 25 years. And I want to make sure that we talk about in the city of Buffalo the terrible impacts that redlining and other racially discriminative practices led to in our community, because a lot of these numbers that you see here follow right in line with the redlining maps that existed. And we're still seeing a lot of disparities within those communities. And again, that's a whole other topic that we could spend a lot of time on. I know I'm going very quickly through some of this. So then to shift from like, why are we doing this work and how are we doing it? I mentioned before, research funding is a cornerstone of what we do at the Heart Association. And so I wanted to talk a little bit about emergency cardiovascular care as one of our flagships that we do, because we are a leader across the nation and also internationally for the work that we do for teaching CPR, but not just the teaching of CPR and the education, the research that goes into establishing the guidelines for emergency cardiovascular care. Hospitals, health systems, everyone that gets CPR and AED training is utilizing some of our research that we do here. So it's so crazy to see that pathway from research to implementation. Again, talking about consumer education and how the research gets translated into a way for people to understand. I love this slide because so often when I'm talking about CPR intervention, you ask somebody, when do you do CPR on an individual? And people say when they're having a heart attack. And I want to clarify for everybody here, a cardiac arrest and a heart attack are two very different things. You perform CPR on somebody when they're in cardiac arrest. It means their heart has stopped. A heart attack can lead to a cardiac arrest, but a cardiac arrest can actually occur for a number of reasons, everything from drowning. If your heart goes into an irregular electric rhythm, it could then stop working. Drug overdoses, choking, just having an airway blockage can lead to cardiac arrest. And sometimes there's underlying congenital heart defects actually that can cause a cardiac arrest. So really important for everybody in a case of a cardiac arrest, 2 steps, hands only CPR. First step, dial 911. Second step, push hard and fast in the center of the chest. That right there can save a life for somebody. So quick poll in the chat box. 2 things I've taught you today. If anybody can say what the acronym is for spotting a stroke, and the 2 steps for hands-only CPR. See if anybody knows that. And then to wrap up today, I love, we just actually unveiled this within the last 2 weeks, I think, the Life's Essential 8. Over the last few years, new science, new research has come out. For anybody that may have remembered Life's Simple 7, it has now transitioned into Life's Essential 8. I'm so happy that the good doctor is here today with a preventive cardiology background because he's going to talk a lot more about this. But you can learn so much about your heart health by going to mylifecheck.heart.org. It is free. You can take a health assessment there. And what it's going to do is walk through your 4 key health factors. So, do you smoke? Do you get enough sleep? What does your diet look like? And are you getting enough physical activity? And then your 4 health measurements, your blood pressure, your blood lipids, so your cholesterol levels, your total cholesterol, your weight, and your blood sugar. You can take the assessment if you don't know your medical numbers, like your blood pressure or your cholesterol or your last time you had a fasting blood glucose. You can absolutely still take the assessment without those numbers. You can create an account and you can actually go back and take it any other time that you want. So I'm going to wrap up here and I look forward to questions and hearing from folks in the Q&A later. Thank you.
Thank you, Lisa. Before we move on to Dr. Matthews' presentation, we thought it would be a great idea to incorporate a stretch break. Research has shown that stretching has numerous health benefits. It can improve blood circulation, posture, and increase levels of serotonin, which is the hormone that plays a key role in bodily functions such as mood, sleep, and digestion. So while educating you on how to improve your heart health, we thought it would be beneficial to incorporate one of the ways to do this during this webinar. So that being said, I will lead us all through a few stretches that are very easy and will be relaxing. So please stand up behind your chair and follow along. And these will all be very easy. So even if you've never stretched before, you don't know what you're doing, this will be just a good time to relax and just breathe. So we'll start off just by closing our eyes and rolling head from side to side. And while you're doing this, make sure that you're feeling that your neck is stretching out. If you feel that there are any knots in your neck, take a second to just sit there and breathe through it. I find that if I'm feeling a knot somewhere that's particularly difficult to stretch, just sitting there for a second and breathing through it. If you inhale and just scoop up all that stress, all that tension, and then when you exhale, you just release it all out. It's very beneficial and it helps get it out. So moving on, we're going to roll our shoulders. A lot of people hold all their stress and their tension in their shoulders up here all day. So just rolling them can be a good way just to stretch it out, get your body moving. And then we're going to do a front arm stretch. So with one hand, you're going to grab the other along your tricep area and just pull it to the front. And so you feel a stretch right along your shoulder and your upper arm area. Make sure to utilize your breath while you're doing this. And we'll do the other arm. Next, we'll just roll our wrists. It's amazing how much, tension you can release just from rolling your hands, ankles, your head, just a little bit. Then we'll move on to our ankles. You can't see my ankles, but I am rolling them. We'll go to the other ankle. So moving on, if you can do this, if you feel that you're physically able, we're going to do a slow roll down and roll back up. And so while doing this, you want to make sure that you feel each of your vertebrae elongating. There's a little space between each of your vertebrae, and we want to elongate that to relieve some of the tension from always sitting at our desk, or standing up, or whatever physical activity that you're doing. This is a good way just to stretch it out and give your back a chance to relax. So I'm going to turn to the side and show you how to roll down. So we're just going to follow out slowly and just breathe. If you feel there's a specific spot that is very tense, you can just sit there for a second and breathe through it. And when you roll down, touch the floor. I know it's difficult. It is difficult for me as well. Just hang out here for a moment. You can sway side to side to loosen up your hips a little bit. And then when you're ready, we're going to roll back up slowly, one vertebrae at a time. Really feel that stretch. I always feel so much better after just that. So last thing to do is you can hold on to your chair or a wall or whatever, or if you have really good balance, maybe just don't hold on to anything. But we're going to grab our ankles from with one arm, and then we're going to align our knees so they're next to each other, and we're going to stretch our quads. I know my quads are always pretty tight, so this is really good. All right, and that's it. So I hope you all feel relaxed now. By incorporating these few simple stretches into our daily routines, we can alleviate a lot of stress in our bodies, which can then improve our physical and mental health as well. And as you can see, this only took, 4 minutes, and yet I feel so much more relaxed now. And my mind also feels so much more energized and prepared to hear Dr. Matthews' presentation, which, speaking of which, Dr. Matthews will now present.
Thank you, Sylvia. Can you see my screen?
Yes, we can.
Okay, well, let's begin. And Thank you. And I really appreciated that ability to stretch and relax prior to my discussion. I'd like to thank Ms. Neff and the American Heart Association for the presentation that she provided. Let me begin by saying that my goal over the next several minutes is to review a little bit of the cardiovascular anatomy, what things that we see with heart disease, how do we diagnose it, how do we evaluate it, how do we treat it, and how do we prevent it, ideally. That being said, let me start by saying that for the most part, when we think about heart disease, we're looking at individuals who have issues with the ability to pump blood. And we're going to come back to that topic over the next several minutes. One of the aspects of heart disease is the fact that modern life, which has been phenomenal in very many ways in terms of making us able to, or allowing us able to enjoy many varied activities, has also impacted our ability to live a heart-healthy lifestyle. And I'll utilize this cartoon as an example. On the one hand, we have the hunter-gatherer who is relatively slim and trim because he or she has to do their activities of daily living, going to get water, going to get food in a variety of ways, doing activities that they're not able to utilize modern conveniences. In the lounge chair, we have an individual who is overweight, watching presumably a television show, who has his bag of chips and may utilize a car to go a variety of places, and may not be getting the adequate level of exercise or appropriate diet. So modern life has conveniences, but very much the cost. So let's talk about heart disease and how this modern life may contribute to that. We're going to define heart disease as any disorder that impacts the ability of the heart to function correctly. So let's think about this as an umbrella term. Heart disease, as I will utilize it or define it over the next several minutes, is going to focus on the ability of the heart to impact the heart's ability to pump blood. Now, why do I focus on that? All of the activities that we undertake to address heart disease, whether that's angioplasty, bypass surgery, any of these, is to maintain the ability of the heart to pump blood. In contrast, when that ability is impaired, that's when individuals will have problems. If you think about it, right now, when we discuss artificial hearts, those are devices for the variety of instances are just there to pump blood. So our ability to pump blood may be impacted. Let's take a step backwards and we can say, what aspects of either our lifestyle or disease processes impact or affect that ability to have normal heart function, to pump blood? And I'll focus on, for one of our discussions, the presence of atherosclerosis. Let's look at this. Here's the heart anatomy course distilled down. The heart is a muscle, and overlying it are blood vessels, which supply the heart itself with nutrients and oxygen. That ability for the heart to get its adequate blood supply is necessary for it to function normally. If it does not receive that, then it will have impairment of function. Let me give you an example. On the left-hand side, we have the normal heart function. And we have here 4 chambers: left ventricle, left atrium, right ventricle, right atrium. But the important aspect is that the heart is pumping, and you can appreciate that by it squeezing in. Every time it squeezes in, it pushes blood out through the aorta, and it ejects blood, so-called ejection fraction, or the ability of the heart to pump an adequate level of blood flow to the various organs and tissues. So on the left-hand side, we have a normal heart. In contrast, we have a heart on the right side here, which demonstrates an abnormal ejection fraction. And let me just go back, see if I can get it. I apologize, oh, there it goes. We can see that the pumping ability of the heart is impaired. And in this pictorial display, the heart appears to be enlarged and it's not pumping as effectively. Let's see. So if we take, for example, that their heart is impaired, what are the signs and symptoms that we see? Well, I'll give you an example of a patient I saw a week ago, a young lady who came in and described the fact that she was experiencing shortness of breath. And when she would do her normal activity, she felt extremely fatigued. She had chest discomfort. And she wasn't sure whether this was her indigestion or whether this represented something more concerning. And what is necessary under these circumstances is to say, well, what signs and symptoms of heart disease are present, and in particular, coronary heart disease? The ones that we look at most commonly are chest discomfort, discomfort which may occur in the neck, jaw, shoulder, or back, individuals who have nausea, fatigue, shortness of breath. They may have palpitations or an irregular heart rhythm. They may feel anxious, experience sweatiness, or dizziness. Now, in this particular instance, the young lady described indigestion, she described shortness of breath, and she described fatigue or inability to perform her activities of daily living to the level that she had previously been able to accomplish. So there was, based upon her description, there was a significant likelihood that something was going on. Whether it was heart disease, we had to pursue further. Again, let's take another step backward and say, well, what are the causes and risks of heart disease? So let's look a little further. One of the causes we think about is the development of atherosclerosis. Now, we've all heard the term hardening of the artery, but this is the deposition of a waxy material within the blood vessels of the heart. When this waxy material is deposited in the blood vessel, it may obstruct the blood vessel and prevent the blood vessel from providing an adequate amount of blood flow to the heart muscle itself. And here's a display. We have a blood vessel that is normal. We have one that has a partial occlusion with the deposition of that waxy cholesterol plaque. And we have one that's 95% occluded by that plaque. The point from this is that when we have a normal blood vessel, adequate blood flow is able to traverse the vessel and go to the muscle, the heart muscle itself. When we have blockage, this may be to a degree that so impairs blood flow to the heart muscle that the heart has to declare that. And it may declare that by not pumping effectively. It may declare that by providing for chest discomfort. It may declare that by providing for shortness of breath. If we look a little bit further, we can use a time lapse to show what the appearance of the blood vessel will look like as days, months, years go by. We'll see that atherosclerotic plaque form, and then when the plaque ruptures, a blood clot forms, and that blood clot, ladies and gentlemen, is capable of obstructing the blood vessel, providing for a heart attack. So with the development of this obstruction, the individual may have shortness of breath, chest discomfort. When the blood clot forms, then that is the basis for heart attack or myocardial infarction. And let's think about the young lady that I presented. This is what her blood vessel may appear to look like. We can see a normal caliber to the blood vessel, and then we see it narrow, sufficiently so that the arrows are pointing to that very, very thin line, indicating that the blood flow and in this case, the contrast agent that we use to show the blood vessel diameter is markedly reduced. And then we get, again, a larger portion of the blood vessel. So this is an area where there is extreme reduction in the ability of blood to traverse this segment. And by virtue of that, we would expect that there would be chest discomfort, shortness of breath, exercise intolerance, a variety of different issues that may be a consequence. Okay, what might have provided for this, or what was the basis for this? Well, Ms. Neff kind of alluded to the fact that there can be a multitude of issues that can provide for this. Foremost can be the presence of high blood pressure or hypertension, an elevated cholesterol, smoking, or diabetes. Now, if you think about it, these all are particular illnesses that are epidemic in our society. So if we look at these four things, they by far and away may contribute to the genesis of atherosclerosis and eventual heart disease. So how do we prevent that? Let's talk a little bit about that. I'm going to start by saying that if we look at the top three, high blood pressure, hypertension, high cholesterol, and smoking, these are a deadly trio. Those are the ones that first and foremost will lead to the development of further heart disease and cardiovascular impairment. If we look at the others, obesity, physical inactivity, diabetes, stress, all of those as well may be contributing factors. The one overlying theme to these particular risk factors is, ladies and gentlemen, they're all controllable. We have the capability of addressing our lifestyle with exercise and dietary modification, addressing our blood pressure with lifestyle, dietary modification, salt reduction potentially, and utilizing a variety of medications to address high blood pressure and cholesterol if needed. Smoking is well within the purview of doing it or not, but I would suggest for all of us to consider, for our loved ones, for our family and friends, smoking is one to avoid. With the remainder, again, lifestyle, dietary modification, exercise, all of the cornerstones. So we have a lot of the ability to impact all of these. And I'll put stress here as well, because I would like to emphasize it's not the presence of stress, because we all encounter stress during the course of our day, but it's the manner in which we address or that we allow the stress to impact our daily life. One of the benefits of having Sylvia demonstrate those stretching techniques are, again, if we can do those types of techniques and other behavior modification techniques, stress can be modified or mitigated to some degree. So what about other risk factors? Well, these are the ones that are not controllable. Gender. We know that men may be at increased risk for a variety of reasons early on in life, and then women tend to catch up. We don't have control of our hereditary or our family history, so we're born to who we are born with. And to the degree that heart disease or cardiovascular disease is present, there may be some genetic predisposition. And lastly, age. As we age, there is an increased likelihood of cardiovascular disease. Now, can we modify that to some degree? Perhaps if we, again, lifestyle modification, exercise, dietary control, yes, we can. But if we live long enough, we will have some degree of medical illness, and cardiovascular disease may be that one condition. Okay, so one of the aspects, and I was pleased that Ms. Neff described it, is that there are differences in different ethnic groups for a variety of reasons. One of the aspects that I was that I learned about and have been explaining is that in the United States, cardiovascular disease is significantly increased in African Americans and South Asian populations. These are individuals from India, Pakistan, and the like, in comparison to Caucasians. There's an increase of stroke risk in African Americans, Hispanics, Chinese, and Japanese populations. And one interesting feature, years ago, there was a study that looked at Japanese individuals in Japan, looked at their cardiovascular rate prevalence, looked at the individuals who had migrated from Japan or emigrated from Japan to Hawaii, where there was a significantly increased risk of cardiovascular disease, and then looked at individuals who had left Japan and lived in San Francisco, where they were having the highest rate. So again, all of the same ancestry, but the difference was those individuals had adopted a more Western lifestyle and all of the potential difficulties associated with that. And you might say, well, what would that consist of? Well, fast food, an increase in the amount of fat, cholesterol in our diets may have been a contributing factor. So things to consider. Okay, let's go back to our patient who said she was having symptoms, and what can we do about that? Well, the first thing we can do is say, what issues can we, or what testing can we undertake to look at the individual? We started out with a history and physical examination, which is the foundation, because that points us in the right direction. We look at the cholesterol values, because that will also assist us in knowing if the individual is at risk. We will look at that echocardiogram, and those were the images I attempted to show, where we could look at the heart and whether it was pumping adequately. We might supplement this by performing a stress test, a nuclear myocardial imaging test, or a coronary angiogram. Let me give you an example. And we've all heard about the stress test, placing an individual on a treadmill, utilizing an electrocardiogram, watching the blood pressure and symptoms in conjunction with the EKG to see whether there were changes which might indicate the presence of heart disease. We might also look at or enhance this by performing what we call a nuclear myocardial imaging study. And this is a study that allows us to inject a material, a nuclear agent, into the vein of an individual and looking to see if it is distributed in the heart in a symmetrical fashion. And let me show you an example. This is an individual who had that, what we call a nuclear myocardial imaging study. And in the bottom portion, we see in panels B, D, and F, these are images at rest, where we see a homogeneous appearance of this radionuclide material through the heart muscle. Here it looks like a donut, and this material is carried wherever blood flow is carried. And here it looks like a upside down U, and here we can see it, a U on its side. Contrast this to the individuals in the or to the same individual with exercise, and we can see that in contrast to that homogeneous appearance throughout the muscle, there are points where there is lack of blood flow, as evidenced by the change in color. We don't see that orange, bright yellow appearance, which would indicate adequate blood flow, or in this case, the material, that radioactive material that is carrying or that is carried by the bloodstream. So based upon this, again, we can presume that there is diminished blood supply to the heart muscle. And indeed, we can even get an appearance or identify where this blood flow impediment was. And this corresponds to that individual. Let's take it a step further. We have now this patient who has had symptoms. We've gone through their history. We know that they're at risk. We now have identified the appropriate testing modalities, identifying where the risk or what the risk constitutes and what the problem, where it lays. Let's take it further and say what treatments are available. Well, we have a variety of treatments. We have medications. We have treatments such as angioplasty or stenting. We have surgery, and we have lifestyle modification. And I emphasize that the first three are treatments that we can implement. The last one is the most important to assist in preventing a recurrence. For example, if we perform a stent or a bypass on someone and they go back to their same lifestyle of smoking and dietary imprudence, they're going to go back to having the same problem again. So here's an example of an individual with plaque. A balloon is placed across that with a stent. It is blown up, and the stent is deployed and props open the blood vessel. Great result. And that's what we would desire. Additionally, we have an individual who might have bypass. Again, blood vessels, and that's that red artery that lies on the heart. And in the individual who has an obstruction, we can take a blood vessel from one of the other large arteries and pass it down to the area of the obstruction, or past that obstruction and bypass that obstruction, such that we are able to provide blood flow to the heart muscle. Now, again, the goal is to provide blood flow so that the heart can perform its activity. If I would like, or I'd like to end on one note. Any of these treatments are miraculous. They are instrumental. The adage that is often attributed to Benjamin Franklin about an ounce of prevention is worth a pound of cure, that is very much true for this, because we'd like to intervene by having our patients exercise, eat properly, quit smoking. I didn't talk about sleeping, but that's crucial. Avoiding alcohol, maintaining a normal blood pressure, losing weight, doing all of those aspects early in life and adopting those lifestyle modifications. Because if we are able to do that, if we are able to do those things, we can dramatically impact cardiovascular disease prevalence in our country. I'm going to end there and say thank you very much. And if I'll be welcoming any questions as we go into the panel.
Thank you so much, Dr. Matthews, for your presentation. So if anyone has any questions they would like to ask either Lisa or Dr. Matthews, you can raise your hand or also type out the question in the chat.
It looks like we do have one question posted by Diana Bridges. I think that's Dr. Diana Bridges. And she wrote, how often do women present with atypical symptoms of a heart attack, and how are they often misdiagnosed?
That's a great question. Unfortunately, there's a lot of bias. Women present very commonly with symptoms which are not the typical chest discomfort or squeezing chest discomfort radiating into the neck and the back. It's important when we see women as a patient and we take a history, if they offer any of those symptoms, to have an open mind regarding the possible presence of cardiovascular disease. And I focused primarily on coronary artery disease, but we see women who will have problems with the aorta, aortic dissection. We will see women who will have pulmonary emboli. They're all of the cardiovascular illnesses that we typically see, we have an extra level of suspicion or concern if we encounter a woman patient, because we appreciate, and the question and the questioner highlighted an important aspect, that women are often it's often attributed to anxiety or things that may be, how should I say, it's not as complete an assessment as we might like. So the antenna should be elevated, or we should have a high level of clinical suspicion with everyone, but in particular with our women patients.
Thank you for that answer, Dr. Matthews. And I just wanted to also point out that I believe Lisa Neff just posted some resources for Go Red for Women the American Heart Association does, which kind of aligns perfectly with everything you were just explaining. So thank you both. Feel free to type your questions right into the chat box. While we wait for those questions, I do have a question of my own for both of you. How did you end up kind of pursuing this kind of career trajectory? Like, how did you know that you wanted to pursue and learning more about the heart, working with the American Heart Association, pursuing med school? So for both Lisa Neff and Dr. Matthews, how did you kind of choose this path for yourself?
Lisa, why don't you begin, and then I can chime in.
Sounds good. And Dr. Matthews, I think you're still screen sharing, just FYI.
I apologize.
No, you're good. I ended up getting into working with the American Heart Association a little bit by happenstance. My background was psychology in college, and then I ended up going into AmeriCorps Vista. That's actually what brought me to the Buffalo community, serving here in Buffalo and falling in love with the community, and realized that I wanted to do work really focused about digging into the community a little bit more and helping in different ways, and falling in love with nonprofit work. And that is really kind of what led me to, when I went out to Connecticut, started with the Heart Association out there. Public health is just such a huge area, and I think the pandemic really elevated a lot of public health folks and the need for a solid public health infrastructure within our country. And it's just, again, kind of happenstance, but work that I ended up falling in love with. Hope that answered the question. Over to you, Dr. Matthews.
Okay, well, for me, it was part personal and part realizing. When I was, I think, maybe 10 years old, my dad had a heart attack. And at that time, there really weren't very many therapies that they could do. They put people to bed for, days and literally weeks at a time, but there were no angioplasties. Surgery, open heart surgery was a really new technique at that time. So it became apparent as I grew older and went into medicine that things were changing. And what was present many years ago, now there's a lot of opportunity to be able to undertake. And that was kind of the guiding principle. So I saw that we were able to impact patients and give them a lifestyle and a second chance, if you will, one that many patients didn't have prior to that.
No, that's absolutely fantastic. Just to kind of like hear both of your stories. They seem different, but they're also very similar in the sense that there's just kind of this commitment to helping the community around you, and just kind of it just kind of works, and it's fits everything, and that's fantastic to hear both those stories. And while you were explaining those stories, we have some questions coming in. We had a question come in about blood clots. So Noah asked, when the blood clot forms in the artery, could that potentially be carried somewhere that would be fatal?
Great question, Noah. Yes, and let me, the blood clot, when it forms in the artery, it can block off the artery. So that in and of itself can prove fatal. The blood clot in the artery, it can go farther down the artery, and that may or may not carry additional issues. The concern we have when the blood clot forms is that, again, it can damage the heart muscle, that it can provide for abnormal heart rhythms, and as Ms. Neff described, it can provide for what we call sudden cardiac death or sudden cardiac arrest, that time when the electrical system becomes unstable, we have abnormal heart rhythms that lead the person to collapse. And for lack of CPR or other resuscitative measures, the person dies. So the formation of the blood clot in and of itself may be a harbinger of things that are even more problematic. Great question.
Thank
We
you.
have another question also that asks, at what age are women and men most at risk for cardiac arrest?
Well, let me take a step back, because I don't know about what age they're most at risk for cardiac arrest, but I'll go to a previous talk that I have given. Cardiovascular disease begins very early in life. And how early? During the Korean War, when the soldiers were coming back, what was interesting was the autopsies identified that these young men, these were in many instances teenagers or early 20s, already had very significant atherosclerosis or atherosclerotic plaque. And that served as kind of an impetus to say, oh, this begins very early. So how early does atherosclerosis begin? Does heart disease begin? Probably in our teenage lives or even earlier, depending on the lifestyle, the diet that we have, the level of exercise and activity that we're engaged in. It can begin very, very early. So in our teens, I often would make a joke that if you, when I was growing up, there were drive-in theaters. If you went out to a drive-in with your girlfriend or boyfriend and you had a milkshake, then you were beginning the process of atherosclerosis, realizing that that milkshake was probably not the most healthy thing at that point in time. So if you go to fast food restaurants, again, same thing. But to the point of the question, when do we see risk beginning? Early in the teens, for both men and women. That can be modified, certainly, depending on the lifestyle changes that individuals engage in.
Thank you. We had another question come in during that explanation, and it was about, and this kind of fits, I think, everything you were just explaining, Dr. Matthews. Is there any amount of alcohol that is considered beneficial for cardiovascular prevention? So I imagine with the young adults, when you hit that legal age, this kind of starts to come into play. So,
well, these are great. This audience is phenomenal. One of the recently identified statements is that there is no amount of alcohol that is considered healthy. Now, put this into perspective. Years ago, not that long ago, we would say, oh, a glass of red wine was potentially heart healthy. And we base this on the Mediterranean, France lifestyle there. What we are appreciating is that alcohol has a variety of detrimental effects, not only in terms of the muscle, but the conduction system, potentially contributing to the development of an abnormal heart rhythm called atrial fibrillation. So circling back in answer, there is no amount of alcohol that is considered safe or healthy. Now, does that mean you can't have a toast at a wedding or a bar mitzvah? No, but alcohol, again, we used to say in moderation. I don't know that there is a moderation. So we should probably put that aside.
It looks like we have just one more question that came in. So I think this will be our last question for tonight. It's been such a popular viewing, so thank you so much. But our last question that just came in was related to exercise. So how does exercise reduce hypertension? How much should the average male and female exercise to reduce the likelihood of heart-related health issues?
Great question. Exercise does a number of things. Number one, it assists in keeping the weight down. And that's very important. Number two, it assists in modifying those cholesterol metabolites within our body. Number three, it also assists in maintaining appropriate or normal blood vessels. If I can take it a step farther, how much is appropriate exercise? Well, for my patients, I say a good rule of thumb, if you can exercise 20 minutes for a session, at least 3 or more times per week, at least 3 times per week, then that should be sufficient. The goal is to be able to help the heart to maintain a normal heart rate. And when we exercise, we're, I don't want to say stressing the heart, but we're allowing the heart to function efficiently. So if we can exercise and perform at a level that's relatively high, then our activities of daily living become much, much easier. So in answer to your question, perhaps we should request our patients to do those exercises 3 times a week, at least 20 minutes at a time.
Thank you so much. To be conscious of time, since we're running a little over, we're going to halt the questions here. If you do have any remaining questions, checking out the American Heart Association's website would be a great place to start. They have wonderful infographics. I was exploring it myself earlier. So direct your kind of concerns there, questions there, and there's a good chance you'll find a great answer there. Thank you so much, Lisa Neff and Dr. Matthews, for joining us today and helping to make this heart and health wellness webinar fantastic. And again, thank you to our audience. We hope that you enjoyed this webinar, that you learned a lot from it, and that you found this was a great way to spend your evening. Thank you and have a great night.
Thank you.
Thank you, everyone.